Oh, Lily.
Good morning, everyone. Thank you and welcome to the TMC media briefing on vaccines. As with past media briefings, we'll have some brief introductory comments from our panelists today, and then we'll follow that with media Q&A. Media can submit questions during the course of the chat by either writing a question in the chat box, texting or chatting me directly, Diana Pashota, or raising your hand. If you raise your hand at the end of the panelist discussion, I can call on you, unmute your mic, and you can ask the question out loud. If you have any questions during the course of the briefing, you can send me, Diana Pashota, a message and I can respond. Now I'll turn it over to Bill McKeon to start our briefing today.
Thank you, Diana. Good morning, everyone. This is a series that we hope will be helpful working with our media experts in bringing messaging, real-time messaging out to the community as this, not only the COVID-19 pandemic progresses through our community, but also the good news of vaccines on the front. I'm joined today by Dr. Paul Klotman, who's the President, CEO, and Executive Dean of Baylor College of Medicine, and Dr. Mark Boom, who's the President and CEO of Houston Methodist Hospital System. So just a few points before we move in. We have 5 vaccines that you're aware of: Pfizer, Moderna, AstraZeneca, J&J, and Novavax. Couple of points here that, as you're all well aware, that on Thursday when the FDA met, on Friday they gave emergency use authorization, and they'll be meeting later this week on Thursday to review the Moderna vaccine. So everything's moving quite quickly. We thought it would be really helpful to just kind of set the framework. There is 5,000 healthcare providers that have enrolled in Texas. We expect about 250,000 doses, and that will be shipped to 109 hospitals in 34 counties for Texas. And so for that, and obviously those are going first to the protecting our healthcare workers, our frontline workers, and protecting our vulnerable population. All TMC institutions have been registered and stand ready, and you're going to hear a great deal about the rollout of that from Dr. Mark Boom in a bit. We have 24 approved sites within the Texas Medical Center, and roughly we are getting 25% of the first week allocation. I remind you that first week allocation is actually rather small, and the volumes will grow in time. So I thought it'd be important first to turn to Dr. Paul Klotman to really talk more about the vaccine, the Pfizer vaccine itself. So over to you, Dr. Klotman.
Okay, thank you. It's really kind of an amazing accomplishment to get a vaccine within a year. Things that took sometimes 5, 10, as long as 20 years to develop. And everyone is a little, I think, shocked by the speed of development. But I think it's not so surprising if you think about what's been going on scientifically. So the first thing is that the whole use of an mRNA platform has been under investigation for almost 30 years. And really around 20 years ago, scientists began to figure out how you could take mRNA and get it into cells, but it wasn't very efficient, or it was often broken down, didn't express a lot of protein. And then there were some great developments with liposome delivery mechanisms. And also advances in the mRNA itself, rather than using the traditional nucleotide structure, which is the way it appears in the body. They use the nucleoside, which is just the basic kind of building blocks of mRNA. So you had all this confluence of science, and both Moderna and BioN were leaders in this well before coronavirus ever happened. So they were already doing nucleoside mRNA chemistry and had liposomal delivery systems, and were doing a bunch of vaccines in other diseases, including flu, HIV, and a bunch of things. So combine that with the tremendous advances we've made in sequencing. Think about the start of the Human Genome Project, where we went from being able to, I remember doing a sequence, getting 50 nucleotides, running a Sanger gel in my lab all day long. And now you can get a sequence of a whole person, in a day. Well, all that technology is available, and the coronavirus sequence was available 2 weeks after the disease developed. And so when you're doing an mRNA vaccine, which is basically taking the very alphabet that produces proteins, it's extremely easy just to flip over the sequence from, oh, I was doing flu, I'll just take the coronavirus spike protein and make that. So it wasn't a huge development process to come up with another vaccine using the same exact platform. And that's what happened with Moderna and BioN. They had that platform already going. And so it was very easy for them to put in the sequence of the spike protein and develop an effective vaccine. The second thing about speed is that it's really hard to do clinical trials when the disease is fairly rare. So, you know, you have to wait sometimes years to finish a trial in looking at an anti-cholesterol drug or aspirin or something like that. It takes years and years and thousands and thousands and thousands of people. Well, when everybody around you is getting sick, it is really pretty easy to enroll 40,000, 50,000 people. Look at what's going on. We have 2,500 people being getting sick every day in our own community. So it's extremely easy to enroll 40,000 people and get to your endpoints. And that's the other reason why everything happened so quickly. It was easy to make the vaccine based on just switching the sequence. There were so many people sick, it was easy to complete the clinical trials. Phase 1, 2 were almost done simultaneously, and phase 3 happened in a few months. And so and then the drug companies themselves said, we're not going to, do this or even ask for emergency use authorization until they had 2 months of safety data. And it turns out the mRNA is incredibly effective. It does two really important things. It induces both your memory, your immunologic memory to react to the spike protein, and it also induces an antibody response. And all the side effects so far have been really the body responding. It's the immune response, you are responding, you get all this stuff released, all these cytokines released, and you get low-grade fever and achy wakey for a very short period of time. But that's your body telling you you're responding. And to have a 95% efficacy is really remarkable. In flu, you hope for 60%, 65%. So incredible advances on the mRNA front. Not surprised that they are the first ones in. The ones behind them are a little bit more complicated, and they use a viral vector. So you take a virus that's very common, it's empty, it's almost like a cargo ship, and you put the protein inside, and it induces an immune response that way. The problem with those vectors is that we've often seen that adenovirus as a kid, and so you have an immune response to the adenovirus in addition to the spike protein. So that may not give you as strong an immune response because you're generating immune response to two proteins rather than one. To counteract that, what they try to do is get an adenovirus we haven't seen. So in the case of J&J, they're looking at adenovirus 26, which is relatively rare in people, and so most people haven't seen it before. That's a good thing. You're not getting a booster response by just putting in that virus. And the other one is the AstraZeneca one, is actually one that's in chimpanzees. So hopefully, unless you're breeding chimpanzees at home, you haven't been exposed to that. So those are the two coming along. And then the other one that's starting is Novavax, which is basically just taking the protein itself synthesized and putting that in a nanoparticle with a bunch of spike proteins around it, highly immunogenic. It's with an adjuvant. An adjuvant is something that stimulates you to have a more immune response. The mRNA itself in the Moderna vaccine and the Pfizer vaccine and BioN vaccine is the adjuvant. In this case, it takes something else. And there will be many other. There's so many in development right now. From killed virus is being developed in China and in Russia. Our own Peter Hotez has a protein with an adjuvant one going on in India. And again, there's so much disease out there. It'll be pretty easy to get these phase 3 trials completed. And I expect very soon to have many, many vaccines available. And I'm happy to answer any other questions about them.
Thank you, Dr. Klotman. Let me turn to Dr. Boom. We've heard about the complexities of how you take how when receiving the Pfizer vaccine, the conditions it has to be maintained. How do you handle distribution across, particularly you run one of the largest systems in Texas. How do you really disperse that out carefully? Can you walk us through the tremendous amount of preparations that you and your team have been making for some time?
Certainly. Thanks, Bill. And I do want to reiterate that it is a tremendous amount of preparation. And we literally have 6 or 7 teams at any given time focusing on different aspects of the whole delivery chain and the logistics of doing this to sort this out. And we've been preparing for quite some time. And I want to thank all of those individuals for hard work and for what looks like it should be a very smooth and well thought out process. As Bill mentioned, and we've all heard this obviously in the press, this vaccine from Pfizer BioNTech requires very deep cold storage, minus 70 degrees Celsius. The Moderna, which we hope to come out in a week, does not require quite as cold a temperature, so that will be easier. And some of the others that Dr. Klopman was talking about, we would expect would require even less. So there are some significant logistics, and that's one of the reasons why you're seeing a limited number of hospitals around the country and in Texas get this in the first week here, is to actually sort out some of those details. And because there are a number of very large, distributed, sophisticated systems like ours and like others that are based in the Texas Medical Center who have that cold storage ability really at baseline. So what we know right now is that tomorrow we should receive the first part of our week 1 allotment. And let me start by saying this is all shifting information literally sometimes several times a day for us over the last couple of weeks. So we've been informed across our hospital system 13,650 doses will be our first week allotment. Put that in perspective between our employees and our affiliated physicians, we're in the 32,000 individuals basis. So when you start thinking about how do we vaccinate the very front lines, that 13,650 actually will do a very good job for us at getting into a pretty good proportion of our staff. Now, what we'll receive tomorrow is the main hospital, our academic flagship hospital allotment, which is 5,850 doses. And then hopefully over the course of the next few days, we receive the other 8,000 or so doses that we are expecting. We would expect tomorrow to vaccinate a couple hundred people. We've been preparing starting Wednesday to vaccinate, not knowing when we would get the supply. It's turning out to be approximately when we thought. We thought it might be late in the day. Tuesday, now it looks earlier in the day. So Wednesday, we will start full force. We can do 2,100 a day. So really with what comes in the next day, we're able to get to every one of those 5,850 doses really by sometime Friday. And so we're hoping that the rest comes in so we can continue to vaccinate. The process is relatively straightforward, but there's a lot of details. We will have people vaccinated every 5 minutes, but over the last couple of days, advice came out or guidance came out from the CDC on some observation time after shots are received. So everybody needs to be observed for 15 minutes and a limited number of people may need to be observed for 30 minutes. That actually adds to the complexity. So we're sorting all of those things out, but we're excited to be able to get those workers vaccinated. So let me explain a little bit about how we prioritize. And I know how other partner institutions across the Texas Medical Center in the state are doing as well. We literally created a tiering system within our own institution, a relatively small group of tier 1, which, when we didn't know how much we would get was if we get a very limited supply, these are the people who are in a room, very, very high level of exposures to COVID. And that's a relatively small number out of 30,000, but it's a very large number given that we have 30,000 people. And then really the bulk of our physicians, nurses, others fall into tier 2. So our strong hope is we will get all of our tier 1 and tier 2 individuals vaccinated very rapidly. That is obviously something that gives us a great deal of optimism going forward. We're also working with a number of outside entities for towards the end of week 1 as we get into that last part of our allotment, or perhaps in week 2. So some of the fire departments, Fort Bend, Houston Fire Department, we're working with a lot of home health agencies. That's a very critical group because, of course, if you think about a home health nurse, he or she is going into a patient's home who is already by definition ill and vulnerable, and in many cases, very high-risk individuals. So that will be a very important group, and many other community partners as well as we work through the next few weeks' supply. As soon as we're given the authorization, our goal is to get to higher-risk patients as well. We've created our own tiering system as well that will adapt based on governmental guidance over time. But at the present time, really, when we look at the highest risk group, which are people who who are older, as well as have a couple health problems. Just in our databases, that's about 70,000 people. So we'll be pushing to get people immunized at higher risk as soon as we possibly can. I think that will most likely, if we get the kinds of supply that we're being told we should expect, be around the turn of the year. So really around New Year's, that first week in January, we hope to be getting to patients. But again, all of that depends on the supply coming to us, which has been a shifting target, and one which we're expecting will continue to be a shifting target as this is complex. And we're talking about every state and every region in the union. So.
Mark, I have a question for you. I was actually asked this question 3 times just over the weekend, and it was from people that were in their 60s and 70s. Some had comorbidities, some did not. And their question was, should they be reaching out to their provider, or the provider is starting to reach out and identifying those subset of patients that do have comorbidities that are invariably more vulnerable to COVID?
That's a great question, Bill. Thank you. Actually, I would ask that people not reach out at the present time, because we just don't have the information to give you. And, we've got, the highest numbers of COVID patients in-house we've seen since the end of July. We've got a lot going on, and then we've got all this vaccine to administer, and we've got all the monoclonal antibody administration going on. It's a complicated time with a lot of hope involved, but we've still got some rough road ahead of us. We will, and if you think across all of the systems in the Texas Medical Center, you think across Harris Health as a safety net, you look at all of our partner federally qualified health centers and many of the clinics in town, all of those have lists and ability, particularly in, obviously with electronic medical records, to pretty quickly identify those patients. So we will be going out to the people who are able to get this early on. Over time, we hope, and I don't know when that will be, of course, that this will start opening up, and it'll be open up more generally at CVS and Walgreens and HEB and other places like that. And so there'll probably be multiple options for people who are eligible. But I do think you will see eligibility, kind of moving down sort of a risk tree over time.
I was asked another question, Dr. Boom or Dr. Klopman. One person asked me, knowing that there are 2 shots for the Pfizer vaccine, when a person gets their first shot, is the second shot in reserve for them? In other words, not worrying about supply chain, and maybe another month, assumingly we'll have more shots or more vaccines at the time. But is that part of the strategy when immunizing someone, that what you need to do relative to supply chain?
So what the government has told us is don't hold shots in reserve. They, in other words, if we give out, the 5,850 that come tomorrow, or the 13,000 plus that we'll have over the next week, plan in 3 weeks that we will receive that same amount of shipment to cover those individuals. Now, the trial, is at a 3-week interval. It doesn't give, exact guidance about, how long can you go after the 3 weeks. But if other vaccinations are a guide for that, there is some wiggle room. So it's not that, you must be there on day 21. There will be some timing and wiggle room. And the other good news that we're seeing in the vaccination data is that, kicking in around 2 weeks, we see people starting to develop some really good immunity. Now, let me be really clear. You need to get your second shot still to finish that series to get durability. But, when we look at a healthcare population of healthcare workers, if we can start vaccinating this week, really by the beginning of the year, many of those employees, most of those employees who get a shot, will have a significant degree of immunity already, which is really good news as we go into an even bigger surge here and need to preserve our workforce and make sure they are safe and able to come into work and care for the population as the numbers continue to grow, unfortunately.
Let me just say one thing about the first and second shot issue. In the clinical trial for the Pfizer vaccine, there were 10 severe cases. One of them happened in a patient who was about 2 weeks after their first shot. So it's important. The second shot is really important. No one had severe disease after the second shot. So it's really important to, that people don't just get one and think everything is cool. They need that booster shot.
Right. One more question, then I'm going to turn it over to Diana for the media on the call. The question about patients that have already been infected with the COVID virus, they may have been a light reaction to it or a heavy one, about their need to get a vaccine. Can you share with us why that would make sense or not make sense?
Yeah, I can help with that. It's weird. You would think that natural immunity would be as good as a vaccine, but it's not the case. And the reason is And this has been looked at very specifically. It has to do with the neutralizing antibodies that are generated. So if you look at people who've gotten a natural infection, they generate neutralizing antibodies to several different aspects of the spike protein in various conformations, as well as a few antibodies that are not to the spike protein that seem to interfere with the ability to get infected. Unfortunately, the best and most effective antibody is the one to the spike protein in a particular conformation that is in the vaccine. And so it's much better to have a high titer to that particular conformation of that spike protein than all the other things. Plus, there is some concern people get sort of a hyperimmune response. It's usually to the with the antibodies, the antigens that are not that spike protein. So even if you've had natural immunity, it may not be as long lasting as the vaccine would be. And so we're not going to try and parse that out. Everybody should get the vaccine, even if you've had COVID.
Great. Thank you for that. Diana, let's go back to you. I know you probably have a number of media queued up for questions for Dr. Klopman or Dr. Boom.
We do have a number of questions, and we have some questions that are non-vaccine. So we'll save those to the end so we can get to the vaccine ones first. Starting with Dr. Boom, all frontline workers have been invited to schedule their first dose shots. Do you have a sense of how many or what percentage of workers have already elected to do so?
You know, I don't have the exact percentage, but a very fair number. Obviously not 100%, just like any other group of people. Some are taking a little more of a wait and see attitude. So what we did was we opened up to that first tier, got as many signed up as would sign up, opened up to the second tier, got them signed up, and actually have even opened up past that, not to give vaccines now, but just to be in the queue to make sure that we are able to get through our population. You know, I liken it a little bit to a slinky. You know, if you ever watch a slinky move, right? The beginning moves and then the other part moves quickly to join it. And so we're taking that strategy. We're taking the individuals who say, yes, I want to sign up, and sign them up quickly. And then we'll pull along the others who may be a little more reluctant, who may want to take a wait and see attitude, et cetera, et cetera. So I think we will get there to very, very high levels of our population of employees pretty rapidly. And of course, you know, and let me qualify that by saying of those employees who we are inviting, because we, you know, are not scheduling every single employee yet at this point in time, but we'll do so as quickly as we can and as quickly as that makes sense. You know, obviously you have employees running the gamut from a nurse who goes in and all day long is spending time in a room with a patient, and physicians who do the same. But you've got housekeepers, you've got food personnel who come in, and of course you've got a whole army of people around the institution interfacing with patients who are keeping the institution running and keeping those other people running. We've got all of the physician office space and staff and others that are also seeing patients in an ambulatory setting where they may see patients with COVID. So the goal is to get to all of those individuals, but that will take some time as we tier through that.
A second question related to your answer there, as it relates to clinicians' offices in the communities, where do they fall in this first wave?
So we've invited all of our affiliated medical staff, and we're helping a number of community partners as well with their medical staff to get them vaccinated here in this first round. What we've then been told through the government is the workers in those offices, so the nurses, the receptionists, others that might be in one of those offices, they fall down a little bit lower tier-wise, so we're hoping to get to them in the next couple of weeks, but that's going to depend on supply and also guidance from the government. But all of those individuals really, since they do interact with the public and healthcare settings, need to get vaccinated relatively quickly here.
And when do we expect healthcare workers will begin receiving the vaccine? Immediately after it arrives, will there be a short lag time? And over what period do we think it will take to put out that first wave of vaccines?
So from a Houston Methodist perspective, we will receive the vaccine tomorrow morning. We got to get it starting distributed out, obviously, to our vaccination sites. We've got 250 people that we're going to work at each site just to work through some of the logistics in real time tomorrow afternoon. And then starting Wednesday morning, 9 different sites across our 7 hospital system. We have a doubling up in the medical center and one outside of the hospital to get to some of those employees. And an employee can schedule anywhere around the system. So if they live out in the community, they can schedule out there, even if they work downtown or vice versa. We've got them scheduled out right now. We've got about 10,800 employees on the books, on the schedule to do that. And so we'll go through Friday, and with what we get tomorrow, we will have exhausted supply, but we are expecting the other 6 of our hospitals to receive their supply over the course of the next few days, and then we will continue going. And then we don't yet have details, no one does in the state, about week 2 or week 3. We do know that that's the week where a lot of nursing homes and others are going to get their vaccine, which is a really good thing. And so we'll just sort of play that by ear as we learn more, but we hope to know this week how many to receive next week, and that looks to be the cadence that we will be on for some time. But again, I emphasize this is a moving, it's a moving, fluid situation, and we've told our employees, look, we'd rather get you scheduled, be ready to go if it comes in, and we'll push you back a day or 2. And honestly, if it gets here earlier, we'll move you up a couple days than to not have you scheduled. So we've been working very hard to do that.
This may be a question for both Dr. Boom and for Bill. Is it safe to assume similar processes are taking place across other hospitals within the medical center? And what's the coordination been like with city, state, and county officials?
Sure, I'll start that off, and maybe Mark or Paul, you want to add into this, but it's been very close. We continue not only to have our morning CEO calls, but we also join in, all of the leaders of the medical center join in with the mayor's team, as well as the county judges team. So we stay rather closely linked. We do that every Tuesday and Friday to really kind of compare notes. As you imagine, the distribution's happening from the state level as it rolls out into the various provider institutions. So many of those leaders sit on the advisory groups, so they have good intel, real-time intel. And obviously both Dr. Boom and Dr. Klopman here from the representing all the major hospitals. So they're different pieces of information, but they dovetail really nicely together. So the coordination is actually quite close, but as Dr. Boom said earlier, there's still waiting for information. I mean, there's been a lot of work in preparation, but quantities seems to be the one part of the supply chain that is not quite clear exactly what the numbers are. Dr. Klopman or Dr. Boom, you might want to add to that.
Well,
go ahead. Go ahead, Dr. Klopman.
Well, I was just going to say we're all, each of the hospitals are getting their allocation. They're all working. We're all working to do our staff. It's interesting. I think it's the right approach. And Mark alluded to this earlier, to get the frontline caregivers, particularly hospital-based employees, vaccinated first. And then as it rolls out, it'll get to physician offices, and hopefully by the end of, I'd say 2.5, 3 months, the rest of the public will be able to get access to vaccines. And those will probably need to be administered through CVS and HEB and Walgreens and other places. They have a lot more contact. Remember, we don't contact the entire public. We only contact the people who come to our health system, and we can only reach out to the people we have a record of. But there are a lot of people who aren't in our system and still will need vaccination. And I think eventually it'll end up being people who have to seek out the vaccine at their local pharmacy or Walgreens or whatever it is. Hopefully that'll be within, I don't think it'll be earlier than 2 months. Hopefully it'll be by 3 months from now, but I think it's in that time frame.
We've had great collaboration with the city, with the county, and with the state, literally on the phone, over the weekend with individuals, as I'm sure they are not getting much rest right now. Several times actually over the weekend at the state level. What I've said to them is, listen, we can be a huge part of the solution, but we can't be all of the solution. Obviously, we need the CVS and Walgreens and HEB and all of those, a very distributed network. But we can ramp up just Houston Methodist alone, and I know my colleagues at other institutions at Texas Medical Center would say similar numbers, to several thousand people a day. So, I mean, if you think about the Texas Medical Center institutions, we can get into the tens of thousands, if not even, 50 to 100,000 a week if we really got the supply coming here. So it can be a very big part of that solution. And what we have uniquely is that ability to identify people at highest risk. So rather than just opening things up widely in an age band, we can actually say, let's look at our oldest patients who also are quite sick and really at high risk of dying, so we can bring that risk of dying, the risk of needing a hospital bed, down as quickly as possible. So frankly, I've been urging, give us as much as we can get. We will get it in arms. We will get it in people's arms quickly. I've said often, and I know they've said that at the state level as well, a vaccine sitting in a freezer doesn't help anybody. And so the goal is to get it to the right people as quickly as we get it. And so my goal and what we've pledged is get us as much as you can each week. And by the time you get us the next week's supply, we will have used the supply from the week before in the right people, and moving forward as quickly as we possibly can.
You know, the just to throw in the logistics of this are pretty daunting. If you think about our community achieving herd immunity, where we need to have 80% or so, 70, 80% of our population vaccinated. If you think of just 7 million people and 5.5 million need to be vaccinated, as Mark was saying, we have the ability to do tens of thousands. We actually would have to do close to 40,000, a day for 120 days to get to that herd immunity. So it's a daunting task. So hopefully we'll get halfway there within the next few months, and then we'll get the rest of the way there by hopefully the summer, and we can start thinking relatively normally by midsummer, and hopefully we'll get to attend a football game by September. But that's kind of the logistics that are, it's not an easy thing to do.
I actually, I think a lot of it's going to be dependent on supply. So of course we are strongly hoping Moderna comes out, basically a week behind the Pfizer BioNTech, and that a couple of those other candidates that Dr. Klotman talked about are going to hopefully be in a January, February timeframe or somewhere in that, because the more supply, obviously, the better. If you think about a normal flu season, now, the flu season lasts, year round, but the peak of it really is, November into March. So the vaccination is September to March that we do most people. So let's just call it 6-7 months. We vaccinated about half of the US adult population who gets a flu shot. Now that's one shot, not two shots, but we vaccinate about half just using that infrastructure of CVS, Walgreens, HEB, the hospitals, the doctor's offices, etc. This one's a little more complicated, obviously, with some cold chain requirements, at least for these first two vaccines, and particularly for the first one. It's a little more complicated with needing 2 shots. But I believe, I'm an optimist, I believe with coordination that we're talking about, we can get this done if the supply is here. It's daunting, it's a big task, but we can work to do that. Very importantly, what we've reached out to do is to say, let's look at our community partners and look at the FQHCs, the Federally Qualified Health Centers, the clinics, others like that, where we will work with them to identify vulnerable populations who may not be in the hospital databases, the homeless population, many others like that. So it's going to take a very concerted effort with the city, with the county, across all of those entities to get this accomplished as rapidly as possible. But I do think supply, hopefully, well, I hope it's not the rate limiting factor, but I think we can sort out the operational logistics, and then really as quickly as we get the vaccine, we will get it to people.
What would you say to those who are called vaccine hesitant, people who are concerned about the vaccine? And how do you plan to use your experience as healthcare providers on the front lines of receiving the first doses of the vaccine to help support people's better understanding about how the vaccine works, its safety, and any after effects?
Well, I'm going to get the vaccine as soon as I can get it. And if you want to take a picture of it, I mean, anybody can watch it. I think this is one of those things, everybody weighs risks and benefits. I mean, we're always doing that. 50 people die each year from, lightning strikes, but that doesn't prevent anybody from going outside and playing golf. And 40,000 people die a year driving their cars, and that doesn't prevent people from getting in a car. We just had 300,000 people dead in the United States. It's more than World War II, and the development hasn't been rushed. The safety profile has been excellent within the first 2 months of giving it, which is the usual time frame when there are complications. So as best we can tell, it's one of the most effective vaccines, and it seems to be incredibly safe at this point. So I would, I would rush to get a vaccine because we don't know the complications of having it. People say, well, it's not so bad. Well, a lot of people have died from it, and we don't know the long-term complications of having COVID-19. So I think it's really important that people, weigh the personally, the risks and benefits, and I would get vaccinated. It makes not a lot of sense to me not to get vaccinated. Will there be some untoward event? For sure. You give it to 100 million people, there's going to be some complications, but they're going to be small, and they're going to be relatively small. But I think it's just so obvious that this is a disastrous disease for people, and the sooner everyone participates. The other thing about everyone pitching in, do it for yourself because it'll help protect you. But when we get to herd immunity, it starts protecting people who are unable medically to get vaccinated. There are people with leukemia and cancer and allergic diseases that can't get vaccinated. And the only way to protect them is for everyone around them to be vaccinated. And so not only are you protecting yourselves, you do begin to protect people that, who are vulnerable, medically vulnerable, as well as people in your family. So I would strongly recommend it to everybody. Happy to be photographed getting vaccinated as soon as I can.
Yeah.
So, if you look at the course of the last century, vaccines transformed life. And my wife does a lot of vaccine work, and one of her favorite T-shirts is "Vaccines cause adults." They allow us to survive through childhood and to be healthy throughout our lives. The problem is so many people haven't seen the diseases that, anymore because we've extinguished them, and we've gotten a little complacent around vaccines, and unfortunately have even an active anti-vaccine movement. With this one here, we all see what this does. This has killed 300,000 Americans. And as Dr. Klopman said, we don't understand the long-term effects of this disease. And so, I talk to people, and I have, kids running age from 15 to 25. And I say, I don't really worry about the short-term issues if they were to get sick, but I don't understand what's going to happen 5-10 years down the road from COVID, which we've seen with SARS and some others. So I don't want them or anyone else getting sick with the disease. So the risks of this disease so far outweigh any theoretical risks of the vaccine that this should be a no-brainer. Unfortunately, there's some hesitancy out there. There's been politics out there. But as Dr. Klopman started with at the beginning, which I wholeheartedly agree with, this was not a rushed process. This was a facilitated, expedited process based on, in some cases, decades of science that are out there. And we have really great data to support this. So what I say to our team is, look, we have to be the leaders, whether it's the leaders in the institution, our physicians, our nurses. We go first for good reason, which is to protect all of those individuals and keep them available to care for the community. But we go for good reason also, which is to show the way for the community that this is safe, that this is the right thing to do. So we are being very purposeful internally about making sure, really across all walks of the institution, that we will model that. I'll give you a little anecdote, which is when we sent out our first prioritization to start scheduling with employees, and medical staff, the most common email I got was from some group of medical staff saying, hold on a second, why weren't we first? And so our medical staff, the doctors who work across Houston Methodist, whether they're our employees, whether they're people who are on our medical staff, they rushed to the front line. They said, I'm a physician. I know this works. I've watched the success of vaccines over the decades. I've watched the horrible impact of COVID-19, and sign me up first. And so we've had a tremendous, wonderful response from our physicians and our clinicians, our nurses, the people who know best, and we will keep pushing that through them. They will help lead the way, but it's going to take a very concerted effort internally and externally to convince the public that this is the right thing to do. Really, it's our social duty to each other. This has been a really lousy year. Well, we have a chance to turn 2021, particularly the second half, into a pretty good year. But it only will happen if we all do this together, or we're going to wake up next year and be sitting there saying, boy, we missed our opportunity to really extinguish this terrible disease and get back to a semblance of normal. So we're strongly hoping everybody works together, links arms, and does this together.
And I would add to that often you've seen entangled not only the health losses to our community, but also the economic losses. And I would argue that the fastest way that we are going to see our economy return to us, as Dr. Klopman and Bloom shared is we have to pull together. This is in the same way that we respond during wars. We are in a war, and the sooner and the faster that we drive towards herd immunity, the sooner that we're going to be inviting people to travel into Houston, opening of jobs, traveling around the world. And I also anticipate, and you're starting to see this around the globe, that there are going to be limitations on those people that do not take vaccines in countries. You're already starting to see legislation around that happening. So if we really care about ourselves and doing our duty as citizens to protect one another and our families and their families, and also to bring our economy back, I think that those are both equally served by a rapid uptake of the vaccine across our community.
A question as it relates to uptake, there is some concern about the cost of the vaccine. Can you help provide clarity to people around the issue of cost?
Sure. The vaccine is completely free. It's being provided, as are many of the supplies to administer it by the federal government. There is the ability to charge about $18 for an administration fee to insurance or to Medicare, Medicaid for the federal government. But the reality is, if someone is uninsured, we're not going to charge that, collect that. So really, I think no one should avoid this because of concerns about cost. This is a case where this is getting supported nationally as a public good, and I think that's a great thing.
You know, and it should be that way. The government fronted the billions of dollars to the companies to develop it quickly. So basically took away the risk, the financial risk for developing their platform. So it's appropriate that it could be free to the public.
Two technical questions, and then I have a panelist or two, question or two that I'm going to get to live. Are mRNA vaccines considered safer than protein-based vaccines? And do we have any sense of certainty around the timeline for Moderna going through the process that Pfizer just went through?
Yeah, so it's, you know, these are new vaccines. This is the first time an mRNA vaccine has ever been approved for use. So the short-term answer is they look to be just as safe, if not safer than protein-based vaccines, but we won't know until we follow it much longer. But again, most of the complications happen within 2 months, and none of the companies were willing to even request emergency use before 2 months of data were in. So far they appear to be incredibly safe. And there's a lot of theoretical reasons why they would be. By being mRNA, they don't get in. It's complicated, but there's no reason why they would have any impact on the genetics of a cell. They don't get into the place that you can screw that up. They're rapidly degraded, and so these should be both theoretically and practically should be quite safe. They do produce protein, so if you had a reaction to the protein, it should be similar to getting a protein vaccine itself. So I think they'll be equivalent. I mean, the real immunity comes from the translation of the RNA to protein. And so your body is the manufacturing the protein rather than some cells or culture tissue or, that you then purify the protein and give it. This is giving it to your body that you make the protein. And then the template that is made degrades. Now, there are some self-replicating RNA vaccines coming out that, could have some issues with safety. I'm sure they will be scrutinized. But the reason they're being developed is because live attenuated vaccines are so incredibly effective. And we don't, yet because it's an attenuated virus, it has risk. A self-replicating template of RNA is not as risky as an attenuated virus. And so I think they will be developed, and they may be effective because they can have long-term production of proteins. If you look at the polio vaccine, it's an attenuated virus that sits in your gut and replicates for your life, but it keeps churning out polio proteins that then your body's constantly reacted. That's why you have one vaccination that lasts a lifetime. So these will wane in time, and you might need a booster from time to time. We don't know yet, whether that'll be a year or 2 year or 3 year. It's probably going to be longer than the natural immunity. So that's another reason to get vaccines. It's likely that this will last longer than the immune response to the natural infection. But there's no reason to believe they're less safe. Let's put it that way.
And any sense of timing on Moderna?
Moderna should be 1 week later. I mean, I think it'll follow exactly the same pathway. Pfizer, if you'll recall, didn't take some of the government money and had the flexibility to have a bunch of contracts with other countries. So we're going to get our allocation from Pfizer. Moderna, we bought a lot more, and I think shortly after Moderna is approved, which I'm sure it will be. I mean, I think it's a 100% chance, 99.99% chance it'll be approved. We'll get more Moderna, shortly afterwards. So I think to Mark's point about supply chain, we will start having more supplies, and then we'll have the 2 vaccine strategies, and then we think the Johnson product, the vaccine, will probably get approved by the end of the year. I mean, it's looking pretty good, but we'll see. And then that should be available, in a few months after that. So hopefully, while we're a little bit constrained now by supplies, by 3 months from now, we won't be.
And I would add that, as Dr. Boone mentioned before, the Pfizer, that has to be maintained at minus 94 degrees Fahrenheit. The Moderna is only minus 4 degrees Fahrenheit or 20 degrees Celsius. So easier to manage the Moderna than Pfizer.
And Dr. Boom, you had mentioned that around the first of the year, we may start seeing vaccinations for people that are in the highest risk categories. Can you help define for people what high risk means?
Certainly,
that would be.
And that's a projection based on hopeful supply. So let me be clear about that. None of us have perfect detail, but I sure hope that is the case. We'd like to get to those individuals as quickly as possible. So, we know that age has been an independent risk factor for this. So part of this will be age related. The other part then has to do with other risk factors. So the same ones we've been talking about all along with COVID. So people have any sort of immunosuppression, chronic kidney disease, cancers, heart disease, etc. And so we have a list of essentially kind of highest risk conditions that have been identified by our medical and scientific team internally. We will use that list plus age in order to identify the highest risk, and we'll start with the highest risk group and then start moving down to lower risk groups as quickly as we possibly can. My hope is if we see all these vaccines coming out by the end of the first quarter or so, we might hit the general public. So might get to a point. Now there's a lot that has to happen between now and then, but we might get to a point where it was no longer risk-based, but simply, who would like it based. But the best strategy to prevent death, to prevent overwhelming of hospitals, to cut the number of people in hospitals, really, frankly, is to vaccinate the most vulnerable, most at risk populations as quickly as we possibly can and protect them.
I think that's a pretty good estimate, Mark. I also think by March or so, hopefully, we will have gotten through the highly vulnerable population, as well as the healthcare workers in direct contact. And hopefully by maybe the second quarter of 2021, it's available to the general public. And hopefully by July 1, we're out of this mess. That's my goal. I need to go to a restaurant someplace.
Yeah. I mean, in that scenario, really things start to dial back, I would project pretty significantly in April, May, June, and hopefully some sense of, near normalcy, by the third quarter, so the second half of the year. That's my hope, and I think there's reason to believe that's possible again, assuming that the supply of vaccines comes out, assuming people take it, and assuming we get some additional, vaccines approved to add to the current ones.
2 questions around this interim period that we are in, where we're starting to see the signs of hope coming from the vaccine, but it could take at least 6 months before we reach critical mass and possibly longer. Question 1 is, how does this impact the approach we take on social steps designed to prevent the spread of the disease? And question 2 is, where are we with hospital capacity? And though ICU numbers have gone up, those have not all even close to been attributable to COVID-19 the way they were in the spring and summer. So can you help dissect some of those numbers?
I'll take the first one, and Mark can take the second one. The first one is that the most effective way to prevent yourself and others from getting it is to wear a mask and physically distance and wash your hands. That has not changed one bit. We will be nowhere near critical mass, particularly in the community. We just said that it's unlikely that even the community will be widely available for 3 months. So for the next several months, it is more important than ever that people sort of double down and be sure that they're not putting everyone at risk. No multifamily get-togethers. I know it's Christmas, but if you're gonna get together, it's a nuclear family. Follow the Jim McDevitt McBubble. Really have a very stringent plan, but basically no get-togethers like that. Masks and physical distancing. You do not want to be the last person to get COVID, to get SARS-CoV-2 and COVID-19 before the vaccine. So I think now people should really double down, and we are in a bit of a surge. It's not as bad as other parts of the country, but I'll turn it over to Mark to talk about the hospital capacity. So.
Yeah, I couldn't agree more strongly that it's going to be critically important, really, until we all get some sort of, all clear sign or mostly clear sign that we continue to do the same things we've been doing. We will not reach those numbers. And I'm very concerned about, a situation over the next few months where people start to let their guard down because they think the vaccine's there, because they've gotten the vaccine, and then they let their guards down. And then we, end up with a pretty chaotic situation, and, maybe not get the dialing back that we should be getting of this. So it's going to be critically important that all of those are adhered to. And I think realistically, we're looking at the first 6 months of 2021 that we're all going to be physically distancing. We're all going to be wearing a mask. So I want to reiterate that because it's such an important point that Dr. Klopman made. From a hospital capacity standpoint, as Dr. Klopman said, we're in another surge here. Now, we're nowhere near the rates of increase, the rates of positivity, or the filling up of our beds that we were this summer. That's the good news. But we're also not seeing it stop. So it is, kind of marching up day after day. We'll occasionally have a little flattening out for a few days, and then it goes back up. And so I don't see anything in the near term, and I mean even near term in the next 60 days, that's going to really change that dynamic. And so we've got to keep together as a community, make sure we are not spreading this further. We don't want to be in that same situation we were this past summer. We are in a better situation in the greater Houston market, I think in large part because we learned a lot of lessons this summer. And so people are doing a good job adhering to social distancing and physical distancing and all those kinds of things. But we cannot let our guard down. We must keep that going. A couple things have happened. Because right now we're seeing as many cases positive in the community as we saw at the peak in June, July. Now, I'll caveat that with the data was pretty messy back then, and I suspect it was underreported then and later reported in August. And we are testing more people out in the community, and we're detecting more disease. So there's some other dynamics at play there as well. So we haven't, for instance, gotten to those same levels of testing within a hospital system where we see sicker people. So I think another dynamic is we have learned how to care for people as outpatients. And so fewer people are getting admitted, certainly than in the early days of the pandemic. And then once admitted, our length of stay has continued to go down. Our mortality rates across the Texas Medical Center institutions have continued to go down. ICU needs have continued to go down, but they're still substantial. I've got 7 patients on an artificial lung machine right now with COVID across our system. Those people are incredibly sick, and we've been able to save some of those people, but you wouldn't believe the amount of how ill those patients are, and the resources, and I mean the personnel resources and the time and attention and care and loving care that happens to save some of those individuals. There's still people who are amazingly sick with COVID in our ICUs. You touched on in the question the fact that all of our ICUs are pretty full right now. That's correct. Remember, this is the busiest time of year for hospitals outside of COVID, especially this past couple of weeks and the next week or so before the Christmas holidays. There's always a big surge of care that happens in the hospitals. That part slows down in January, but in January we hit cold and flu season. So we see a lot of people who are ill from that standpoint. So we're going to continue to see a lot of pressure on our ICUs outside of COVID. And so we want to keep those numbers down so we make sure we're able to care for the rest of the community as well.
Let me add to that just to further support Dr. Boom's comments. If you look back on our average number of cases that we would see in a week in July, the highest peak at the time, it was around 2,300 cases. We've seen 2,300 cases last week and 2,040 this past week, daily average COVID cases. When you look at hospitalizations in that same period of time in July, we went from 100 to 240, 50 to 360 cases per day hospitalizations. Now, over the last week, it's slower. It's a slow growth, 147, 155, 174, 190. So that's the slow progression that Dr. Boom's referring to. And from a capacity standpoint, we're still in our phase 1. We have phase 2 and phase 3 to expand further. And also, as you heard, many more of those patients are being managed on an outpatient basis. So from a capacity standpoint, we're okay now, but we really absolutely need our community to really step up their efforts to really not attend group settings at all during the holidays and continue to wear their masks and physically distance.
I mean, look at it this way, the light's at the end of the tunnel. We can get there in a few months. We've been through, now a solid, 9 months to 10 months almost of this. We've got a few more to go. So we're well over halfway if we can get the vaccines out and get people vaccinated well over halfway. And so we can do this, but it takes a lot more caution over the next few months to get there.
Terrific. That was the last of our questions. I want to thank Bill, Drs. Klapman and Dr. Boom for their time this morning in answering the questions. For members of the media who participated today, afterwards, we will send you a link to the recording of this session in case that's helpful to you. And you can also email the TMC media address and we can get back to you with any further clarifications that you may need. Otherwise, I hope everybody has a great day and good luck to the team on this screen in getting those vaccines out and going.
Thank you.
Very much.
Stay safe, everyone.